Hi there. My name's Jessica McCaig. I am a social worker at Boston Children's Hospital, and I have the privilege of chatting with you guys today about how we measure and discuss the quality of life within the nutrition support community. All right, going to start nice and easy. I have no commercial disclosures to share with you guys, no reasons not being paid by anyone special. Like I said, I work at Boston Children's Hospital, but that's about it. So for our agenda and goals today, most importantly, I want to highlight that the importance of the connection within the intestinal failure community is really driven by medical providers and the nutrition support community or consumers, as I really feel like the previous two speakers have spoken well to, and I want to highlight that and ensure that everyone knows that's my primary goal here. Initially, when I shared my idea with the dream team of Oley about talking about quality of life with the nutrition support community, my thought was that I would probably do like a roundtable or a panel discussion, something that would lend itself well for a true conversation between myself as a clinician and folks who are actually part of the nutrition support community. They thought it would be better as a general session, so joke's a little bit on me, but my goal here is that we can talk about this, and you are very well aware that I am not here to preach to you or tell you what your quality of life is or should be, but rather share with you some of the data that we've collected, some of the research that we're hoping to continue to collect, and then to kind of go from there, think about ways that we can do better, think about ways that we can sort of merge, and some of the questions I think have really lent themselves well to this. How can we talk to our providers? How can we work with providers around coming to compromise, coming to a place where we can all kind of agree about what we're looking for? I will use that next point next. So I'm going to do a little bit about me because I think that that's a helpful place to start. As I said, my name is Jessica McCaig. I am a licensed independent clinical social worker in the state of Massachusetts. The PMH-C after my name is, I'm a perinatal mental health counselor and clinician as well, which is something that is near and dear to my heart, but most of the families I work with are have new children, new families, and having a very complex medical diagnosis on top of being a new parent, I think really lends itself well to have that additional certification. A little bit about my background. I went to undergrad in Georgia, and then I moved up to Massachusetts for my graduate degree in social work. I started working outside of my master's in the early intervention community. Some states call that birth to 3 or birth to 5, but home visiting and supporting clients, families around their children's development, whether that was impacted by any medical reasons that they might need additional support and or purely developmental needs. I made my way, honestly, back to Boston Children's Hospital in 2015. I did intern in the NICU at Boston Children's as an intern when I was in social work school at Wheelock College. And I work for the Center for Advanced Intestinal Rehabilitation, or the CARE team, CAIR, at Boston Children's Hospital. I was hired as the initial clinical social worker. There's now 2 of us. I support all of our in and outpatient families, and I work to make sure I'm connecting them with resources, community supports, thinking about different ways that we can support them both in the hospital, outside of the hospital, and beyond that, hopefully. And a lot of the work that I have done thus far, especially from a research perspective, has been around quality of life. It's something that, again, is very near and dear to my heart, and I want to make sure that as we're continuing to talk and think about nutrition support for all of you, that we're looking at the bigger picture, which is quality of life, in my opinion. How did we get here? So as some have already kind of mentioned, the improvement in the survival outcomes of the pediatric intestinal failure population is well over 90% at this point, which is incredible. But with survivability comes the importance of talking about things like quality of life, transitions, and how we can better support the nutrition support community. A lot of the reasons that we have seen an increase in the survivability of the pediatric intestinal failure population is due to the brilliant clinicians, the psychopharmaceutical advancements, therapies, and just the ability for us to kind of think outside the box in a lot of ways. I definitely agree with Dr. Nance in that learning from each other is really important, both peer-to-peer, but also between medical providers as well, which is why we go to so many of these conferences and work so hard to ensure that we're staying up to date with the newest data, research, et cetera, so we can bring that to our patients and families and make sure we're sharing that with them as well. I'm going to take a moment just to acknowledge that I'm using the word intestinal failure, and it is not my favorite word to use to describe this population. I have been told by families, and I would have to agree that as a strengths-based social worker, using the word failure just feels kind of crummy. But due to the clinical nature of the quality of life research that we're going to be discussing, I think it's important that you know that maybe my heart doesn't feel anyone in this room or outside of this room has actually failed in any way. I'm going to try to use intestinal failure, intestinal rehabilitation, potentially short bowel syndrome, and nutrition support community kind of interchangeably. So just my own personal disclaimer. All right, so as we pivot to look at the lens of pediatric intestinal failure as a chronic condition, we want to look at long-term disease factors that factor into the disease and things that we can maybe change about those things. We're very well aware that there's frequent healthcare needs, there's activity restrictions, and high infection risk, multi-organ dysfunction, and gastrointestinal symptoms. In addition to that, many of the pediatric intestinal failure patients that we work with rely on parenteral nutrition for long periods of time, and that really does impose a logistical burden, a risk to their health, and intense medical follow-ups. That affects quality of life. I'm going to define quality of life. Everyone likes a definition slide. Quality of life, oh, that wasn't me, as an individual's perspective on their position in life in the context of culture, value, and within the life that they live, and it's related to their goals, expectations, and standards. That's what the World Health Organization says. It's kind of like a lot of words that don't really mean that much to me, honestly. The health-related quality of life definition, as defined by the CDC, is that it's a multidimensional concept consisting of physical, psychological, and social health dimensions of an individual's well-being. That one I kind of understand a little bit more. Maybe it's because of my clinician-y brain, but it feels a little less abstract to me. I think it's been really hard to talk about quality of life from a medical and research perspective for many of the clinicians who have been researching it for quite some time now because of the subjectivity that is quality of life. My quality of life and your quality of life, the quality of life of the person sitting on either side of you, we can all measure it quite differently, we can look at it differently, and I think that's really important that we acknowledge. So assessing and putting a number or a score on quality of life is hard to do, and it just might not be as meaningful from one person to the next. I like this graphic because I think it kind of shows with an Venn diagram model of all the different facets that go into the health-related quality of life, and how even just one portion of that can really throw off the equilibrium of someone's quality of life or health-related quality of life. What do we already know about pediatric intestinal failure? Did I skip a slide? Nope, I didn't. Okay, sorry. We know that there has been a lot of literature. So beginning in about the year 2000, quality of life became a bigger construct in the research and medical community. Because of the medical advancements, as I've kind of already referenced, people were really starting to think about, okay, we are able with modern medicine to help patients, families, patients of any age, et cetera, live longer. Now, how do we support their quality of life? So we started seeing people start to publish studies, but very small cohorts, specifically within the pediatric intestinal failure population. Some of the things that, these are just kind of snippets of some of just title slides of different research, but some of them reference the impact of short bowel syndrome quality of life, neurodevelopment and how that might impact quality of life, what factors are associated, what should we be considering, generic and disease-specific considerations for the pediatric intestinal failure population, We've looked at parent perception, we've looked at patient perception, and there's just a lot of different perspectives. So as I said, subjective and it can be difficult to kind of figure out exactly where we're going with this. In an effort to not bore you guys too much, I decided to do a Lit Review Light. And for folks who don't know this acronym, it stands for Too Long Didn't Read. And my goal is just to kind of go through this with you quickly so that you kind of have a sense of what was already out there in the literature before now, I guess, but before maybe even like 6 or 7 years ago. The published studies, some of which I already named and many of which I didn't name, are really small n's or sample sizes. They're 30, 36, 52, 7. That's how many patients they surveyed for some of those papers, which is not, there's no shame there. That's how many patients they had to work with, because a lot of centers don't have the patient population that can really support a big N or a big study that can give us better data and more significant information to kind of follow. The data kind of overall suggests that the pediatric intestinal failure population had a lower quality of life than normal, whatever that is. We would expect that probably because, like I said, we know that this goes with long-term hospitalizations, frequent hospitalizations, medication management, having to work with lots of different companies, providers, et cetera. So I think that we can all understand why we would expect that health-related quality of life to be lower. There were different aims between these studies, like I said, patient, parent, caregiver, family, et cetera. And there was definitely some competing of underlying diagnoses, as I'm sure is true for many of you in this room, or for your children or family members who might not be in this room. Few people just have one diagnosis. So what is really contributing to the quality of life? Is it the short bowel syndrome, or is it the autism? Is it the short bowel syndrome, or is it the other medical components that are kind of going on, or just general stuff in people's lives? So just a lot of things to consider, and hard to, again, sort of put a number to and put a really strict definition to, excuse me. So upon my matriculation to the care team at Boston Children's Hospital, I was fortunate enough to become involved with the team in working on developing what we considered a pilot study to assess the quality of life of pediatric intestinal failure patients. The paper that we ultimately published was in the Journal of Pediatric Gastroenterology in 2021, and we titled that The Generic and Disease-Specific Health-Related Quality of Life in Pediatric Intestinal Failure. There's a long story to how this kind of came to be and all the work that went into it, which I kind of want to share because I think it highlights, again, the nuance that is quality of life in this patient population. We began researching a lot of those articles and others about what had already been done in the pediatric intestinal failure community, and we wanted to think about how some of the tools that had already been used could continue to be used, and or what we could add to those in our own doing to ensure that we were supporting this community and getting the best glimpse, a one-time survey of what this might look like. We set out with a number of surveys in our clinic with our patient population. So all the information that I'm sharing right now is just from Boston Children's Hospital Care Clinic, which is our short bowel clinic. In and between the years of 2016 and 2018 is when we sort of launched this survey study in our clinic setting. We ultimately ended up surveying 53 parents and 18 children. The low number of children is because not all children were age appropriate to participate or developmentally appropriate to participate, so all parents and then 18 children additionally. The ages were from 2 years old to 18 years old, and our hypotheses initially were as follows. Generally, we figured that patients with pediatric intestinal failure would report a lower health-related quality of life than perceived by their caregivers and families. So the patients, those 18 kids, were going to tell us they had a lower quality of life probably than their parents would tell us that they thought their child had. The second one was that caregivers would have a lower perceived health-related quality of life as compared to patients who have achieved enteral autonomy. So I think it's also important that I note that we defined pediatric intestinal failure as having required 90 days or more of sustained parenteral nutrition. That could be in the hospital shortly after birth, or it could be in the community over months, years, etc. So the overall thought is that being on PN might make caregivers feel as though their child had a lower quality of life than if they had achieved enteral autonomy. Don't want to give any spoilers, but the tool that we primarily use was called the Pediatric Quality of Life Inventory. It is a validated instrument to measure health-related quality of life. Some of you guys may have seen these before. Some of you may have filled them out before. There's a lot of them. They have disease-specific pediatric quality of life inventories. They have a GI-specific one. They have them for ortho diagnoses, developmental diagnoses, et cetera. We chose this one because, as I said, it was a validated instrument. The surveys were pretty brief and easy to administer. They were developmentally appropriate by age, so it broke kids down by age brackets, and so we could talk about what we would expect those kids to be doing in that age range, and to see if the families felt like how they were performing as we would expect developmentally. It's multidimensional. The surveys are for parents, families, children, and are GI specific, and there is an abundance of reference data. So because this is a validated tool, we have the opportunity to look into a lot of the previous data that has been done and compare our information that we gleaned from our study with retrospective data. This is what the first page of the packet looks like. It talks a little bit about the scoring. It's important to note that the scores are inverse. So, and I'm going to show you on the next slide what the tool actually looks like. But a 0, if something is never a problem, we would invert that to mean that your quality of life would be 100%. So if it's never a problem for me to get to school, then I'm not having a problem with getting to school. So my health-related quality of life related to that specific thing would be 100%. This is a sample of one of the pages of the quality of life inventory for the just general questions. This has nothing to do with GI specific or short bowel specific, nothing like that. The important things here to think about is that we wanted to look at the physical functioning and the emotional functioning of our patient population, as well as the social functioning and then the school functioning. So as I mentioned before, these were developmentally appropriate in terms of if a child was between 2 and 5, this reads if they are going to school. So if they're in a preschool setting, daycare setting, things like that. But if they're not yet there, then you wouldn't fill this section out. And it kind of changes over time. Like when a child would be 15 to 18 years old, we're asking different questions about their ability to participate in school or clean up their toys or things like that. Again, scoring is inversely related, so higher score equals better quality of life. And that was the thing for the statisticians to do. It's not something that I did. Initially, we found a lot of information. We asked some demographic questions as well, which is important to note, and some of those are highlighted on the left-hand side of the screen. Our average age of patients who we surveyed was 6.2 years old. 51%, I think, sorry, I can't really see that far, of our patients were female, and then we had about a 50-50 split between our parenteral nutrition supported patients and our enterally autonomous patients in the patient population we ended up surveying. Honestly, that was like kind of an accident, but it worked out quite nicely for the data. The bottom of the left side of the screen, which I just want to point out also, is some of the other demographic information that we collected that we thought might contribute to the quality of life of our patients and families. So things like whether or not they had an ED visit in the last month, if they had had a hospital admission in the past year, and if their child required overnight care. I'm sure that I'm preaching to the choir here and saying that I think that those things really disrupt and challenge people's quality of life. On the right-hand side of the screen, it's a little bit, we're going to get a little bit more into the nitty-gritty of research, but the top part is the caregiver perceived quality of life of their child. And between the physical and the psychosocial functioning, we found that overall, our patients and families on PN, the families, the caregivers rated the quality of life as higher than the children who were enterally autonomous. completely negating our hypothesis, and we were sort of scratching our heads and wondering, did we do something wrong? Did we describe this wrong? We went back and looked at the data a million times because we just figured it couldn't be right. We then went on to look at the patient reported, so that's an N of 18 of the patients talking about their health-related quality of life, and essentially found the same thing. So it's important that we take a second to stop and think about this, as I said, not that I know your quality of life better than anybody else, but like I said, we put a lot of thought into the hypothesis and what we thought things would look like, and it just didn't really come out that way. We did also use something that's called the GI symptoms module, which asks questions specifically about children's gastrointestinal symptoms. So I have to use the bathroom a lot, I see blood in my stool, I have to throw up a lot, I don't feel like I'm done going to the bathroom. Things like that we figured, and the PEDS QL survey helped us to understand might affect people's quality of life. We didn't end up focusing too much on that data collection. We did do some other comparisons, which I'll show on the next slide, but the meat of it really felt like it came into the general quality of life questions that we were asking. So we then looked at, as I said, there's a lot of these different PEDS QL scores that we are able to obtain. So we looked at our data for the current study. So that's, well, the top part again is going to be the caregiver perceived health-related quality of life. And then we compared it with a healthy population, so children without any known medical diagnoses who completed these forms historically, and then also chronic GI patients who could have any type of GI diagnosis, from like Crohn's disease to irritable bowel syndrome, even IBD, any kind of symptoms that related to chronic GI disease structure. And we found, again, some kind of interesting data, not as shocking as the first data, but interesting nonetheless. Caregivers mostly perceive the quality of life scores for our patient population, the care kids, the short-gut kids, between the healthy and the GI, the chronic GI conditions. So we were sort of falling in this middle ground, which again, we thought was kind of interesting. We don't know that much information about all these patients. As you can see, it's a huge N in compared to our patient population, but it just was sort of interesting to us that we were falling in between what would be considered a healthy child and a child with a chronic GI condition. Additionally, for the for the patients and their report of their quality of life, we saw that they rated their quality of life as lower than the general quality of life. And then the GI chronic disease patients, again, they rated themselves as being a little bit better than that. We collected a lot of different measures. We did so much research, and there's still so much more that we could do, but for the sake of publishing a paper, you have to kind of narrow it down and decide what you're going to talk about. And so these were the big points that we wanted to drive home and share with the pediatric intestinal failure, pediatric GI community. I think that's all I want to say about that. So what's next? As I alluded to, this was a pilot study. And it was a pilot study because it was already some wheels turning between a lot of really wonderful clinicians that they wanted to use a pilot study that we were doing at Boston Children's and a study that Dr. Patrick Javid's team at Seattle Children's was doing simultaneously, similar to ours but different, because we wanted to kind of see how two different teams would approach this and what information and results that they would get. And we came together after we both launched our pilot studies and said, okay, how do we make this into a multi-center study of quality of life in pediatric intestinal failure? Our N wasn't that big. Dr. Javid's N, I think, was like around 72. And so we were both working with good-sized populations, but we're just not getting enough to survey enough people. So Dr. Javid and Dr. Biren Modi, who's one of the surgeons at Boston Children's Hospital, worked to put together this prospective multi-site study of quality of life. This includes all 11 of the hospitals on this slide. So Boston Children's, Mott's, St. Louis, Lurie, Hospital for Sick Kids, Seattle, Children's Hospital of Alabama, Duke, British Columbia, Alberta, and University of Texas. That's a lot of centers, and it's really amazing because this is what our hope is to be able to survey patients from these different institutions and to do this in a longitudinal way. I'm gonna go a little bit into that again. I'm gonna get a little more clinical here. So our hope is that we're able to all use the same survey information and share it with all these different centers. They're going to use it for their specific patient populations. The goal is to do it on an annual basis for each patient. And this is completely voluntary. It's a study. You don't have to do it. It's completely up to whatever feels the best for you at that time. You can do it 1 year, not the next. You can do it for 5 years in a row and never again. Our goal, though, is to talk about and think about what the quality of life is longitudinally for you as a patient, family, consumer, but then also to think about it between sites, centers, and to get this really big number of patients with pediatric intestinal failure and learn more about their quality of life. It doesn't really matter what center you're going to or where you live or how far you travel for your care. What we want to know is what is your life like and how can we maybe make it better? One of the differences with the pediatric, with the multi-site study is that we added what's called the family impact model, another piece of the PEDS-QL inventory. And this, I think, was a real miss in the first pilot study, and I think was really important that we considered, and we did end up able to implement, because it looks at some of the really important things that are affecting your lives. As I look around this room, I know I'm looking at direct nutrition support consumers, but I'm looking also at parents, partners, caregivers, family members, friends, clinicians, et cetera. It is not lost on me that just because you are part of the nutrition support community does not mean that you physically might have a tube or require advanced nutrition support. And this is a pediatric setting that we work in at Boston Children's Hospital. So as people say all the time, oh, you get to work with kids all day, which is not true, but mostly I'm talking to their patients or their families and caregivers. And that's really important to note too, because they're the ones driving to the appointments. They're the ones who are answering a lot of our questions. They're the ones who are giving the interim health history. And again, I think that really needs to be not only studied, but also talked about in the literature. Two examples, there we go. So this is specifically for the family modules, and it asks specifically, in the past 1 month, as a result of your child's health, how much of a problem have you, as the caregiver, as a part of the family, had with emotional functioning, social functioning, having worries that are more significant maybe than you wish that you had, your ability to get done daily household activities or chores, kind of your level of exhaustion. As I mentioned before, we talked about overnight cares, and I know a lot of families aren't able to necessarily access home nursing or overnight home nursing. And then internal family relationship challenges. Do you have help? Are people understanding of your child's medical condition? And are you constantly having to explain that or explain why you can't be present at so-and-so's birthday party or a holiday because you're stuck inpatient, things like that? It's not entirely my study, so I'm not super comfortable with sharing the data of it. There is some data out there, which you're more than welcome to look up or inquire with if you are working with any of these centers. But at the beginning of this year, so January 2024, 460 unique study IDs had been made. So that means there's 63 patients who have been enrolled in the study. But there has been 894 surveys collected, which means we're getting people to do the study year after year so far, which is really great and really important. And again, something that we're working towards continuing for the sake of the data and the greater good. So what have we learned so far? It's a good question. Children with intestinal failure likely experience a lower health-related quality of life based on parent proxy and child self-report data. Children with intestinal failure report a better health-related quality of life as compared to what their parents report. The children and family scores improve with age, but remain significantly lower than other populations. We have some targets. The specific areas that were highlighted with some stars on them in a previous slide were those of statistical significance that were run by our statisticians with fancy degrees and that kind of stuff, that I understand, but I don't think we have to go into in that much detail today. But what the areas that we really saw significant differences in were school, admissions in the hospital, and then also the time. How long does health-related quality of life become better over time? Does it become worse? And how can we support that? So we started doing some stuff. School is super important. One of the first questions that a lot of families ask me, and a family who is very near and dear to my heart in this room today, asked me as I stood next to them in the NICU when their child first got to Boston Children's Hospital was, will he be able to go to school? And that question makes me very emotional to this day. My answer is always a resounding yes. Yes, they will be able to go to school. How can I support you in getting your child there? I'm talking to you about your goals, your hopes, your dreams for your child. Your NICU baby is not going to tell me what their goals and hopes and dreams are. So in the beginning, I really am working off of what it is that parents are hoping for their children. My colleague, Ashley Robers-Bois, who will be speaking about this tomorrow, has worked really hard to implement our school readiness, some school readiness packets, both from physically, we will hand you these papers, but also we can digitally share them with you. And we learned at a prior conference in Toronto last year, 2 years ago, that it would be really helpful if we could have some information for the school specifically, and also for the family. So I've always met families saying, this is what your rights are. It's important that with any disability or medical diagnosis that your child still has the right to an equal education alongside their peers without barriers, and that is on the school system to figure out. But a lot of our kids, school systems have never seen them before. They've never seen a central line. Lots of them have seen G-tubes, and they love to tell us that. But they might not understand your child's unique hydration needs, unique nutrition needs. They think they have an allergy. They think they might choke if they put something in their mouth. And it requires some psychoeducation with the school system. So this has been a huge undertaking, but also I think has really come a long way. One of the few silver linings of COVID has allowed for us to also participate in IEP or 504 meetings, school planning meetings with patients and families across the country and just outside of the four walls of our hospital, which is obviously where they typically occur, thanks to our Zoom ability. And that allows for us to not only support and advocate for our patient population, but just to generally share that psychoeducation or have a nurse come on and talk a little bit more about, well, this is what, Joey needs, and this is why this is important for them. And things change fast for these patients sometimes. So sometimes we have to get online and talk to these folks at the schools lots of different times because we're changing nursing orders and we're telling them new things are happening or things are no longer happening, things like that. So this has been a really big step, I think, in what we've been working on. One of the other things that we heard loud and clear was the cry and need for support. Already referenced, I think, in both other talks this morning, and I think just by way of us being here together at Oley. Families want support. They want to talk to other families. They want to learn from each other. They also want to learn from us. When families come into our hospital for an admission, obviously something is going on that's big, and that's usually our focus. When they come into clinic, they're coming in to have a conversation about where we're at right now and where we're trying to get to, and it's more of a professional exchange, right? Like, here's what we're coming for. Can we wean the PN? Can we go up on feeds? So-and-so's not tolerating this. We have 700 poopy diapers a day. Like, we're trying to get some things sort of fixed in those settings. We started a virtual support group on Zoom one night a month for patients and families who are served in our clinic. For about 1.5 to 2 hours, kind of depending on the conversation. I think most of the parents would let us talk all night, but I have a bedtime. And families like to do it from like 7 to 9 p.m. So fine with me. This is not for me, it's for our families, and it's a means of support, so whatever works for them. We started this in 2021, and again, I think this is a silver lining of the pandemic. This is a poster I presented at the Pediatric Intestinal Failure Conference a few years back. With families' survey responses of how they feel like this is going. Overwhelmingly positive. I think they would love it if we could do it more. There's just not enough hours in the day, unfortunately. But I think this is an important addition to the peer-to-peer support that has already been talked about, and also the opportunity to communicate with clinicians in a little bit more of a casual way. So we're home, maybe we're sort of in our PJs, at least like a sweatshirt or whatever, and we're not here to be your clinician. I'm here to be an active listener, to hear what's going on for you guys and to share with you some of our providers, our clinicians, and other things that are going on. One of the big things, probably one of the favorite sessions, was after what we would call Formula Gate. With the challenges with formula a few years back, we had our dietitians come on and help support and explain to families what avenues we were taking, how we were trying to support them in transitioning folks to appropriate formulas, and keep everyone as safe as possible during a really chaotic and stressful time. Some of the other kind of less data number-y information that we were able to glean from the quality of life pilot study itself, but also from just my experience in working with this patient population for nearly 10 years now, is, again, some things that have already been sort of mentioned. The challenges with out-of-pocket expenses for medications, nutritional supplements, copays, travel expenses, medical accommodations in the home, et cetera. Missed pay due to missed work, due to having to bring your child to the hospital, to a clinic appointment, and then that goes on into young adulthood, obviously, when we have children who are becoming adults who need to get into the workforce and are having difficulty maintaining a job because they can't always be there. It's not like this is cyclical, that we can say they're going to have a flare-up every 3 weeks or every 3 months. We don't know that, and it really does inhibit their ability to participate in the workforce in a comprehensive and reliable way. The lack of equity in Social Security disability insurance payments, if any. The constant reassessment of needs, so for example, home nursing, Medicaid, prior authorizations for medications or medical appointments, again, SSDI or IEP 504 plans, et cetera. So you guys are constantly in meetings, you're constantly doing, you're meeting with people in your home, outside of your home, where did that time come from? You know, it's all taking the time off of work, et cetera, and it definitely does impact the quality of life. And then there's the other piece of transition is the changes in needs. So from an infant to a toddler to adolescence, adult, and then going from there. We're just kind of getting there with a lot of our patients, but it's important for us to consider. Some of the work stuff, which I did already talk about, but the success also in the workforce, I think, is important to mention. Changes that significantly impact families after a diagnosis. So maybe there were 2 parents that were working in the home, but now they both can't be working. Someone has to remain home to take care of one of the children, or has to have a reduced work schedule or something like that. So just really significant impact. Some research does suggest that there's a loss in work productivity or poorer quality of life in the setting of chronic GI illness, not shockingly, and there's definitely more research that's needed to explore this. For the sake of time, I'm going to kind of run through this one because I want to get to these 2 vignettes that I have for you guys. Psychosocial considerations of patients, increased medical trauma. We're constantly poking. We don't really let them control their own body. They say, I don't want to get my labs drawn. We say, well, you have to, left arm or right arm. It doesn't feel very good. There's also a recent paper that was published out of the Netherlands that suggests that about 33% of patients with pediatric intestinal failure will also carry a mental health diagnosis. Now, it's important to note that we're seeing more and more mental health diagnoses over the past 5 or so years in general. So I can't say that that's substantially separate from that, but we know some of these things are going to be comorbidities or happen at the same time. Some quotes from families that, again, I've gleaned over the years from our support group and other places. Insurance and infusion companies run my life. It takes just one ball to drop for your kid to fall through the cracks. What's the difference between quality of life and quantity of life? And my kid is a person and not just a count number. So those are things that really hit home for me, and those are things that I can't necessarily change as a social worker in an intestinal rehab program, but they're not lost on me, and I think that those are places that we really need to do better as a healthcare community. As we've discussed already, there's a lot of room for improvement in this country, in my opinion. I have 2 little case vignettes that I wanted to just run through. We have a little girl who is 14 years old, and she attends school. We had a clinic visit with her, and she was receiving overnight tube feeds. And this was causing her to have overnight stooling and incontinence. As a 14-year-old girl, it's very uncomfortable. I don't like that. I don't want to have to deal with that. And so we had this like aha moment. Of course, we'll just change her from overnight feeds to bolus feeds during the day. She can get those in school, leave the classroom a few times. We write up orders. We support everybody. So great. Except for that, she came back to clinic and we're like, how did it go? Did the transition go well? We're all excited thinking we like did such a great job. And she is beside herself. She wants to go back to overnight feeds because the sheer difference that is her in having to leave the classroom multiple times a day for a bolus feed is potentially contributing to like bullying or just making her look very different from her peers. So we undid that per her request. I think the important thing here is that the medical team assumed that we had this like great fix, and it's so important for us to have these conversations and follow up on them, because just because I think this is a great idea and I don't think it's a big deal to leave the classroom multiple times a day as an adult who has my own level of self-esteem, et cetera, it's not necessarily true for a teenager. And when I was in middle school, if someone told me I had to do anything even slightly different than my peers, I would have had a full meltdown. The next one is a more recent one. I'm calling it a promposal. We had and I want to just highlight the importance that we are ensuring in quality of life that our patients and families are able to participate in things outside of the medical setting, and as much as possible without the need for all their medicalization. So we had a mom email us asking, or letting us know that her son was getting ready for a big night, prom. This is actual literal verbiage right from her email. And that he's usually finishes tube feeds at this time, starts PN at this time. These are all the rates. And she wanted him to be tube free for that night. And so kind of thinking about the timing, she made a proposal of what she felt like might work, backing up the PN and providing tube feeds and an extra bolus so that he would be able to attend prom sans tubes and hopefully feel like just another kid at the prom. It went swimmingly. We agreed this was a great plan. It seemed safe. We checked in with mom. And then afterwards, on Monday morning, we came into pictures of prom and felt really excited that he was able to attend that. No medical drama, emergencies, anything like that occurred. Where do we go from here? So I think it's really important that we continue to, as clinicians and as medical providers, that we create a relationship where we acknowledge that there are challenges for the nutrition support community, and that we want you to know that it's a safe space to discuss this with us, and we can come to the table together and make sure we're having these really important conversations. It's not just about tolerating feeds. It's also about, do you want to go on vacation? You have a big party coming up, holidays, prom, tube feeds aren't working, whatever it is, like we want to make sure the space is safe for patients and families. And I think earlier Dr. Nance said very well, if she had just asked the patient the question as if they were worried about whether or not they had cancer, if she could have just answered that in the first 20 seconds, they wouldn't have had to maybe suffer through 20 minutes of, but that's all I wanted to know, not how you were gonna fix it. And so if we could just start sometimes with, what are your goals? What did you come here to talk about today? Instead of, this is how much weight you gained, this is what your labs say, this is what that says. There are multiple parts of the conversation that need to be had at every clinic visit, every hospitalization, et cetera. And I welcome parents and families to be forthcoming with questions and definitely impress that on their medical teams. It is important, you are important, your children are important, your care is important as individuals, and it is our job to support you in the community setting. I talked really fast at the end, sorry guys. Those are my references, and I'm happy to take any questions. Okay, no questions, no time. But I will be here all week, and happy to chat with folks as they see fit. Thank you guys for letting me.
Can I ask a question? Sorry, that was very loud. Can I ask a question?
It's fine with me.
Yes, okay. Thank you for this presentation, and thank you for bringing this topic to the forefront. It's really important. My name is Swapna Kakani, and I was born with short bowel syndrome and living into adulthood with it. What do you feel have been the barriers or weaknesses to the PEDS QOL tool, and any comments from family members or children who are taking it in terms of struggles or even validation?
That's a great question. Yeah, I think one of the big challenges is that it's not specific enough. There's no room for comments. So one of the things we've run into is specifically for our patient population with ostomies, they really feel like the questions that relate to their quality of life as opposed to children who don't have stomas, there's a real significant difference there. So again, I think it's a great validated tool, and it's something that's going to give us some real numeric data to compare things against, but there's something to be said for some of the nuances that are within short bowel syndrome.
Thank you.
Yeah.
And I commend you for asking about life outside of the clinic and the hospital setting and the impact of that on their lives in the home and community. I have a question more about the specific wording, and I know why you use this tool because it's one of the sort of most studied, validated tools, but most of the questions focus on problems and not on strengths that may be present. And even the emotional ones are about, are you worried? Are you anxious? Are you sad? Is there any thought about reframing some of these questions in a way that focuses more on strengths and getting the child or teenager or family to think about strengths that maybe exist that can then be further developed in a way that will build resiliency as opposed to always kind of focusing more on what problems there may be and how do we solve for those problems.
Yeah, that is a great point. And as I said, as someone who really tries to focus on strengths-based care in the short bowel community and just in life generally, to my knowledge, the PedsQL is very focused on that kind of negative. And then again, like I said, we have to kind of inverse the data to describe the quality of life on a percentage scale. So I don't know if the people who make this huge tool have any potential of changing the language. However, I think that there is an opportunity for us to implement additional aspects of the study to do just that. Like what has changed in the past year? What is different? Like what has gone well? And those are really important questions for us to ask too, and to not just keep this in like a negative way. Like, we know your life is hard, so tell us more about it. It's a great point.